Welcome to Head to Toe with Dr. Tebelele. And it's another lovely evening. We're cruising and looking into TB and the various aspects of screening of TB, especially that we've got new services in the Nelson Mandela Bay. And noting that we ignored TB for a long time and focused on COVID. And now we're back with full force to focus on TB. And once we talk TB, you cannot forget HIV. I've got Dr.
Razia Gaida from Equity Innovations here today. Thank you for inviting me.
Thanks, Razia. You must cool down. This is your space.
Okay.
I understand you are a pharmacist by profession and in terms of papers.
Yes.
Where did you study and how long did it take you and how come you are called a doctor?
I studied right here in Gqeberha. Then it was called Port Elizabeth still. I studied at Nelson Mandela University. That time it was called Nelson Mandela Metropolitan University. So we've gone through lots of name changes here in the last few years. So I started my studies in 2007, finished my undergraduate in 2010 and decided, no, I need to do postgrads now before I move on with life. So I carried on with my master's and then I did my PhD. And that's why I'm called doctor.
You look young. You've done so much, so many milestones in a short space of time.
Thank you very much. I did my PhD whilst doing my community service, which was actually at a specialized drug-resistant TB hospital right here in the Bay.
Or was it your first time you worked with TB? You started with the heavy TB.
I started off with the heavy TB. I was thrown right in the deep end. It was the first time that I was dealing with TB in any kind of real way. Even during our studies, TB was sort of not really given the focus that once I started working, I realized that it should have. Especially drug-resistant TB. It was something that we barely heard of during our studying years. And now all of a sudden you're dealing with medications in doses that you never thought possible that people should be taking. You know, what about side effects? What combinations of tablets? And so many medications, particularly at the time that I started working. Since then, there have been a lot of changes. The number of drugs have reduced drastically. But wow, TB has gone through a lot of changes in the last few years, and I've actually been quite fortunate to be at the forefront of it all.
Wonderful. And Equity Khusela, what are you doing there?
Equity Innovations is a non-profit organization, the aim of which is to assist the South African Department of Health in achieving their health goals. Our particular focus is TB, and the South African government has ambitious goals in ending TB, hopefully by 2030. So it is the...
So end TB 2030, that is the plan?
That is the plan.
Are we getting there?
I think that with concerted efforts, with buy-in from communities, from healthcare professionals in both the public and the private sector, buy-in from the NGOs, I think that, yes, it's doable.
What is your role at, or what portfolio do you occupy at Equity Khusela?
I am the project coordinator for the Khusela TB project, so I oversee its running. I am also responsible for the research involved in the Khusela project. The reason that we've done it as a research investigation is that we want to make sure that the methods that we're using are validated, that they can be easily replicated by other groups, and then also that they can be scalable to a national level afterwards.
Wonderful. You've recently launched a program, a very nice program at Fear Plus, and Fear Plus is one of the hotspots. In fact, there are quite a few hotspots in Nelson Mandela Bay. Fortunately, we are now stationed at Fear Plus. The launch in August, was it?
November.
November. Yeah. The launch in November went so well, and even the department was here. How are things going in terms of numbers, and can you explain what you actually do in terms of on the ground now?
So I think the launch definitely catapulted our publicity. Our staff are now being recognized in the areas, and people are very aware that we're there, and they also know what we're doing. So we're providing TB screening directly in the communities, taking health services literally to the households.
Wonderful.
We have a truck that contains a digital X-ray machine.
truck with X-ray. People pray for X-rays. They didn't do X-ray, and so now you are providing free X-ray
We are
services.
providing free X-ray services. Usually, if you are in the Zwede cluster area, you would have to get your X-rays taken at West End Clinic, and
Yeah.
sometimes there can be quite a long waiting list. So we are providing the digital chest X-rays much closer to the people now.
Wonderful. So waiting time reduced. Access to X-rays free is
Yep.
guaranteed. Why X-ray? Do you pick up more cases with X-ray than the previous method, or is it in addition to what we usually do, sputum and everything?
The reason for the interest around the digital chest X-rays now has really stemmed from the National TB survey that was done a few years back. So the digital chest X-ray actually showed that even if you don't show any symptoms, you could still actually have tuberculosis, and you should still then get tested. So it picked up about 50% more people who would have been missed by just asking them questions if they had symptoms or not. So they showed no symptoms, but the X-rays still showed presumptive for TB, and those people were tested, and quite a few of them then actually tested positive, even though they had no symptoms. So the South African government has now actually adopted the digital chest X-rays as an additional screening tool for TB. So in addition to asking about symptoms, patients can now actually have a digital chest X-ray as well, and it increases the sensitivity and the likelihood of actually picking up TB.
What is the importance of picking one positive TB patients in terms of implications to the family and the communities that they work in?
TB is a very infectious disease. Like our COVID pandemic, TB can be easily spread, and it's also airborne. So if somebody coughs, it's very, very easy for someone else in the household, if you're spending a lot of time with that person, to then become infected with TB. Children as well, kids who are younger than 5 years old are especially vulnerable to TB infection, and also people who are living with HIV, those who are diabetic, and those who have other conditions that maybe compromise the immune system, like cancer. So if we don't pick up a person who is infected with TB, they can continue to infect others in their households, in their communities, in their places of work, places where they hang out for long periods of time. However, if they are detected and they are put on treatment, they will no longer be infectious to others around them.
Wonderful. Ladies and gentlemen, we've got Dr. Gaida.
Yes.
Gaida. Don't say Gaida, it's Gaida.
Gaida.
Gaida. Dr. Gaida is a coordinator at COSELA, which is an NGO working on TB. Uyicacisile ke into yoba eyona nto bayenzayo si-screening. I-screening, it means you then awunyanzelekanga ube kanti ngumntu obonakala une-TB, so singakuba ungajikela nje noba ucinga uba unanto, uyakwazi uofarisha i-X-ray, uyakwazi uthatha isikhohlela uxilongwe, then kubonakala uba una-X-ray. Na into encedayo ke ngoku into yoba xa siphikisha umntu oyi-1 one-TB, uzawunceda into yoba ukhusela yena nabanye from ukusulelana nge-TB, because i-TB sisifo esosulelayo. That's the importance of screening. And we're going to take a short break, and then we'll be back and look into the symptoms of TB in adults and in children, so that we're able to navigate the route as we look into what is happening in Zwede, Fear Plus, and then wherever you are, then it means you've got a responsibility to make sure that you go for screening and then take treatment at TB. Stick to your screen, we'll be back. We're back. Thank you for staying tuned. And Mpumakaba TV, channel 260, we're talking TB and TB screening, because TB is such a burden globally and especially in our province. Not only in our province, but in this region where Akwiti Kusela is stationed, through the eyes of Dr. Gaida, who is the TB coordinator locally. Dr. Gaida, thank you for taking us through what you are actually doing. And then we're talking to our two citizens. We're addressing people in the areas where we go for screening. Here is a truck, here are the nurses and so on. People are confused. There's a lot of halapalu and so on. And there's a lot of stigma and discrimination around TB. Some people be scared to go screening. What kind of symptoms are common that may alert me as an adult that I've got TB?
So the major one is a cough. I think that's probably the one symptom that everyone is aware of. So we say that a cough that has lasted for 2 weeks or longer. Okay? Also a fever, night sweats, and loss of weight. So these symptoms might sound very mild, but usually with TB, they're very exaggerated. So when I say night sweats, you're generally going to be waking up at night completely wet, maybe needing to even change your clothes or even change your bedding. Loss of weight and loss of appetite. Really, you cannot eat the way you usually do, and sometimes your loss of weight can be quite dramatic as well. Those are the 4 symptoms that you are asked in the TB symptom screen, and they are the major hallmark defining symptoms of TB.
Kumuntu ongavayo itibu ibona ngokhohlela isikhohlela sometimes sibe negazi uhle apha esiqweni ungayazi buhla ntoni awusebenzisa into osilima awukhonde ichazela into yoba kutheni ndisihla esikalini ungathandi ukutya ubile kakhulu ubile kube manzi ibhedi ukuthi kufuneka utshintshe namashiti plus nento ubuyinximile ungabiliswanga ngumdavazo ke phofu because zininzi into ezibilisa ebusuku. Once kwenzeke ezo zinto then kufuneka ukroke into yoba ingathi ndine-TB. And then in children, any marked differences in terms of symptomatology?
So the symptoms that we ask for children is a little bit different to that of adults. So the pediatric population for TB is people who are younger than the age of 15.
Yeah.
So usually we will still ask about the cough, we will still ask about fever, but then additionally we also ask if children are failing to thrive. So that means they're not picking up weight the way they should be, and they're also maybe not reaching their milestones when they should be, especially for the very young children, and also if they're fatigued or if they're very tired. So those are some of the slight differences between the adults and the children.
Wonderful. We used to struggle to get to diagnose TB in children because the younger ones, the 5-year-olds, can't cough up and so on.
Yes.
In terms of Acuity and Kusela, are there any extra efforts? The X-ray is an advantage.
Yes.
Are you doing any mantus, taking specimens and so on? How
Yes.
difficult is
It is challenging in children. Generally, they don't have a very high bacteria load in their lungs.
Yeah.
So even if they do cough, if they're able to and they can give us sputum, usually the result is going to come back negative because there aren't actually enough bugs in there to pick it up at the lab. So what Kusela TB project is doing, we're trying to provide as many investigations for the under 5s as we can. So we do provide them with a digital chest x-ray. We do the MANTA or the TB skin test. We're also doing induced sputums or gastric washings because as you mentioned, it's difficult for kids that age to actually cough up sputum. So we're assisting them with little nebulizers or with the gastric wash procedure. This happens at the clinic. It's conducted by a qualified nurse who is properly trained in these procedures. The x-rays are then interpreted by our doctors on the team as well to give us guidance on whether or not the child should be assumed for TB, and further testing will then take place.
TB has long been in existence. We never defeat it, but Acuity comes from the NGO sector, and you've got government arm involved, and then we've got private general practitioners.
Yeah.
What is the strategy? Why is the public sector not enough to deal with TB?
So we're trying to bring together as many different strategies as we can. So as we mentioned earlier, the government's goal to try and end TB by 2030, we need buy-in from a lot of different stakeholders, and Department of Health is just one of them. So by being out there in the community, having people see what we're doing, understanding that TB is a challenge in the area, but that it can be detected, that it can be treated, and that it can be cured, is very important to getting people to demand these healthcare services and treatment for TB. So we've got our community-based activities, we've got our private sector involvement. They reach a broader population, and also we provide hours that are more convenient for some, especially for those who are working, and those who are only maybe available on weekends when clinics are not open to function. So by bringing in all of these different stakeholders, we're really providing our people with the best opportunity to pick up TB and to treat it and then to cure them.
Thank you so much. Talking about stakeholders, you can't treat TB effectively without screening and handling HIV. Out of the stakeholders, are there any people that are working closely with you or that are within the project that are handling the issue of offering people the HIV test and handling that?
So as you're saying, TB and HIV, you can't talk about one without the other.
Terribly twins.
Definitely. South Africa has such a high co-infection rate. So given our close relationship with the Department of Health, any patients who we detect have TB can go to their clinic for HIV screening and testing, counseling. If they are found to be positive, they can access treatment there as well. Any patients who are seeing their GPs and who are detected to have TB, they can get HIV testing done at the GP's rooms as well, and then access treatment through them. We also have developed relationships with other NGOs in the area who are specifically focused on HIV, and we're hoping to form closer relationships with them and definitely then do joint campaigns in the future.
And in terms of numbers, how is the uptake? Are people responding to this great initiative, noting that TB has been here for too long? Maybe we've been moving at a very slow pace. But now you've brought the services to the people and most of these things are free. How is the response so far?
People have definitely taken an interest in what we're doing. There's a lot of curiosity also around the truck and the digital chest X-ray machine. We have screened almost 10,000 people to date. And we have about a 1% yield of positive TB patients. So definitely people are interested, they're keen on accessing services, and they're definitely interested in what we're doing.
There's something that usually confuses people, pulmonary TB and extrapulmonary TB, in terms of how infectious the other one is and whatever. So far, what kind of TB is predominant and which one is more infectious?
It's definitely pulmonary TB. That's also our particular focus in the Kusela TB project. Your pulmonary TB will also be more infectious because when you're coughing, your bacteria are coming directly from your lungs into the air. If, for example, you have TB of the stomach or TB of the spine, it will not be as infectious as your pulmonary TB.
So in other words, TB can affect any organ?
Any organ. TB can affect any organ.
But it's not as infectious as that one of the lungs.
That's right.
So i-TB yemiphunga yiyona esulela kakhulu, and xa ukhohlela into enokwazi ujinga emoyeni ixesha elide. Yiyo le nto sikhuthaza abantu uba kuvulwe ifestile, kuvulwe iminyango so that kungena umoya, kubekho indawo ongena umoya, kubekho indawo ophuma umoya. So that umntu ongena angangeni kulengalenga i-TB. So the more ventilated le area ukuyo, the better. Ayikokuphakama uthi naxa ungena ekhumbini, oteksini nasebhasini, uthi makuvulwe ifestile so kungene fresh air. So that is the importance of infection ye-TB, because eyona isulela kakhulu yile yemiphunga. Xa uthimla, ukhohlela, uhleka, kutaka ezo droplets. And ke ngoku akusoze sikwazi uqhawula ama-chain e-TB uba asikwazi uyenza loo nto. There's something called cough etiquette. Can you demonstrate it for our viewers?
So as in the COVID time as well, this cough etiquette really became a big thing. So it's to ensure that you are not spreading any bacteria to people who are around you. So it is always a good idea to cover your mouth and also your nose as much as you can when you're coughing. So if you do cough and you're in a public space, you can cough into the crook of your elbow. So we do
Wonderful.
For sneezing as well. And even if you have a tissue or a mask and then you just cover your mouth and your nose and you cough into the tissue, make sure that you throw the tissue away afterwards in a bin, and always, whenever you can, wash your hands.
We're going to take a break on that note. We'll be back shortly. TB, TB, TB. We'll end it in 2030 together with you. Stick to your screen. We'll be back shortly. Welcome back to Head to Toe with Dr. T. Nangu Peyo Mpembe. Impembe inakuba na i-TB. That is why ndiphethe umuntu ozandichazela nge-TB namhlanje. And the strategy is end TB by 2030 with everyone involved together with the Department of Health. Dr. Razia Gaida is a TB coordinator at Aphile Kusela. They are based in Fear Plus currently, but by moving from one hotspot to another in order to make sure that we cut the chains of TB infections. Wherever you are, it also means we've got a responsibility, cough etiquette, make sure that you're on treatment if you have been diagnosed of TB, and also subject your family and those that are close to you to screening. You don't have to exhibit all the symptoms, we are screener, but make sure you do, because the TB ekhoyo is complicated. And xa une-HIV, i-TB iyathanda ungathathi the usual route. Ifune sidike ngapha nangapha, kodwa kanti ikhona. Dr. Gaida, a lot of people default TB treatment, or once they stop having shortness of breath, we lose them in the system. How many drugs do we use and for how long for ordinary TB?
For your drug-sensitive TB, the ordinary TB, we use 4 medications, and the treatment is divided into 2 segments. So we have 2 months of intensive phase, and then we have 4 months of continuation phase. So in your intensive phase of treatment, you're taking 4 drugs,
Yeah.
and in your continuation phase, it's 2, and it's at a slightly lower dose as well. So with your intensive phase, you're taking 4 medications. Generally, after the intensive phase, so 2 months of treatment, people start feeling much better. The medication works, you're feeling good, maybe your cough is gone, your fever has reduced, and people feel that, you know what, maybe now it's okay to stop taking my medication. The TB bacteria is a very strong bacteria. It doesn't go away after just 2 months. If you do stop taking your treatment at that point, you will get sick again. And then you're going to come back, maybe a little bit sicker than you were before, and you will have to then start your treatment over. It's very important that once you start your treatment, you continue taking it until it's finished, just as prescribed by your nurse or by your doctor.
In HIV, we used to say adherence. Adherence, even if people are taking PrEP and so on.
Yeah.
Are there any campaigns to enforce adherence to TB treatment? Noting people say the smell, the taste, and so on, and the period that they're going to take them. How do we encourage them to take treatment?
So there have been a lot of strategies that have been tried. Definitely your healthcare workers at the public healthcare facilities will provide counseling to patients. We also have something that is called DOTS, Directly Observed Treatment. So you would have somebody who would be with you maybe on a daily basis, who will be there to support you in taking your medication and to make sure that it is taken properly every day. Peer supporters and support groups in the communities, usually these are people who have had TB, they have been on the medication and they have been cured. So they really have an experience and they can empathize for what you're going through because they've also been there. They provide support to people in their communities who have now been diagnosed with TB and are going through the journey that they've been through before. And for us, the Kusela TB project, we also provide adherence counseling, we provide treatment counseling as well, and we will also provide adherence support to people who are found to be positive and put on treatment through our project.
Okay, you said there are 4 drugs that are commonly used: isoniazid, ethambutol, PZA, and rifampicin. Out of the common side effects, people complain of change of color of urine. There are people who jump to the clinic or come back to the site and say, my urine has changed ever since I've taken these drugs, and they may end up defaulting. How important is it to explain some of the side effects and which pill is causing that?
It's definitely very important that people know what can possibly happen. They also need to know if it's serious or not and whether or not it's going to go away. So the changing of the color of the urine and maybe of the tears and the saliva, it's not a serious side effect. It's not going to affect your health in any way. It is unfortunately a side effect of rifampicin, but it's not harmful to you. Also, side effects may not affect everybody. It might only affect some people here and there, and also after a few weeks, they will also go away.
And then the rash?
The rashes, usually they can be treated with skin creams. They also will tend to resolve after about 2 weeks or a month on treatment. If you're going to experience side effects, that's usually the time frame in which they occur. They will happen early on in treatment, and then after a few weeks, they usually calm down quite a bit, especially things like nausea.
Can I crush the pills into yogurt or whatever, or can I split them? Because vomiting is quite common.
Definitely.
Nausea and vomiting.
So if you do vomit about 30 minutes after you have taken your medication, we do recommend that you take another tablet because the tablet hasn't had enough time to be broken down and absorbed into your bloodstream, so you're not going to get any benefit from it. But if it has been longer than that, then it should be okay. While we always say that it's better that you take your tablets whole, I do understand that it's difficult for some people. I myself really struggle to swallow medication. In that case, it is okay to crush it. It's not recommended, but if that is the way that you need to take your medication and ensure that it's getting into your body, then yes, that is what you do.
Wonderful. People report some pins and needles on their toes and their feet and so on, and I understand that is from isoniazid. Are you giving any protection or prophylaxis to make sure that that minimizes that side effect?
So definitely the pins and needles in the hands and the feet is one of the major side effects that people experience, especially if you are also HIV positive and taking ARVs, because
Yes.
some of those have the same side effect as well. People who are put on isoniazid can be given a small tablet. It's vitamin B6. It's called pyridoxine, and that is generally given together with isoniazid to try and prevent that tingling in the hands and the feet.
Then if my eyes turn yellow, especially with the TB and HIV treatment, lots of tablets and so on, then I get yellow eyes, should I panic and stop treatment?
Whenever you experience a side effect, make sure that you tell the doctor or the nurse who is treating you. Things like yellow eyes could be a sign of maybe a liver problem. Don't stop taking your medication, but try and make sure that you get to your doctor or your nurse as soon as you can. Explain your side effects to them, and then they will decide what is the best way forward for you. Don't stop taking your treatment, please.
Don't stop taking your treatment. Dr. Gaida, let me thank you for now. And let me just give a summary of what we've actually done. Wonderful. Keep on doing what you're doing with Acuity and Kusela. And hopefully people will actually respond to the drug and everything, all the movement, to make sure that everyone is screened for TB. TB is not for certain class of people. It can affect anyone, even us, because we are occupationally exposed to TB. As we are screening other people who can get infected. In summary, xa sizawuvala sithethe nge-TB, sathi TB unakuyibona ngokhohlela, ukhohlela isikhohlela esinegazi, uhle eweyithini, ube nephika, ubile kakhulu xa ulele. Zonke ezo zinto zibangela into yoba uthestwe, but ngoku i-TB ekho i-complicated, naku ungabonakali ncam. So siskrina wonke umntu, noba umntu uziphilela ufit unezigalo, i-x-ray yenziwa kuthathwa isikhohlela, uba siphuma isikhohlela, but i-x-ray kakhulu ngoku iphathi okanye isisixhobo esisetyenziswa ngokuqhelekileyo ukukhangela i-TB. So nawe nabani na, and kubalulekile into yoba xa sifumana umntu oyi-1 one-TB, then sizoze sijonge nabanye aba-around yena to make sure into yoba siqhawula amajeni e-TB. Xa suqalisile i-treatment kubalulekile into yoba ungayiyeki, because kulula into yoba ube ne-MDR, ube ne-XDR, ngomana usenza u-stop and go okanye udefault i-treatment. Xa une-side effect, i-jaundice, inkantsi, i-rash, ukugabha, kubalulekile into yoba uripote kule klinikhi uthatha kuyo okanye kugqirha, zonke ezo zinto, then banamacebo ona ukwazi uba bazodilishana njani nezo zinto. TB can be stopped, TB can be beaten, and we're targeting 2030 shall be the end of TB. Thank you so much for sticking to us, and you can follow us, Aphile Communications, on our Facebook, YouTube, and all over. Then on Mondays at 7:30, Pomakapa TV, your DSTV channel 260, where we educate you with what affects you from head to toe. Thank you so much. TB shall end.